Well, thanks so much, Carl, and it's really wonderful to be back here at Rambam, and I want to thank you for the warmth of your welcome, and also for setting me this very tough exam question. When I saw this on the program, when I was in London wondering what I was going to have to talk about today, I was somewhat daunted. I was especially daunted because, as you know, Britain's going through a little bit of a tumultuous time at the moment, and my authority for making grand sweeping judgments about the world has been somewhat diminished. There you can see our Prime Minister lingering in the background of this meeting, Theresa May there, and your President in the United States, Jeff, right at the front. I think he elbowed his way right to the front of the crowd. So you need to take what I say with a certain modesty and humility. This is what we're going to talk about today. We're going to talk about personal health and the state of the world's personal health. We're going to talk about the state of the world's global health. Then we're going to try and see if we can combine those into a single vision for the future of health in our world. And then we're going to do a little bit of a night smooth thinking and see whether we can take a different frame for our future. And then we're going to look if there are some new and interesting possibilities about how we might shape the trajectory of that future. So let's start, first of all, with how are we doing in our world in terms of personal health? Here is the sheer beauty of equations. Jeff loves drawings of trains. He's an engineer. I love mathematics, and I love equations. And this is a beautiful equation. Look at the symmetry of it. I find it stunning. What is it? It's a method of calculating an age and risk standardized death rate. You don't need to know the details, but the reason is that it's important is that it allows us to do something immensely clever. What is clever is that by applying this equation to every cause of death, across every age group, for men and women, in every location of the world, and for every year, you can calculate something called amenable mortality. What is amenable mortality? It is simply this. It is the disease burden that can be avoided in the presence of high-quality personal health care. And this is the best measure that we currently have for how good our health system is. So how good is your health system? Let's look. So this is a very difficult table, but you only have to look at 3 lines. This is the top part of a league table of 180 or 90 countries in the world and their health systems. And you can take all of the results for lots and lots of different conditions, all up here, and it includes tuberculosis and tetanus and measles and maternal health and various kinds of causes of disease. And then it sums it all up. Unfortunately, the pointer is not working too well here, so I'm going to have to point with my fingers, into this. This is called the Healthcare Quality and Access and Quality Index. And by calculating this index, you can then take a league table and put countries at the top and at the bottom of how well their health system is performing. At the top, you've got Andorra, Iceland, and Switzerland, and you will notice that the dear old United Kingdom is down here. Number 30. Not bad. Where's Israel? Here. Number 25. So your health system is ranked higher in terms of its quality of personal health care than my health system in the United Kingdom. Now, one thing you might notice is there's a country not in that list of top 30. Ah, the United States. The United States is number 35. These data were published 2 or 3 weeks ago. So this is the best measure we have. And Carl and I were having an interesting discussion, because in the series, one of the calls we make is for greater investment into Israel's health system. We still believe that, because you're well below the OECD average for proportion of investment compared with gross national income. However, it's not just how much you spend, it's how you spend. And actually, you're doing a pretty good job. Let's look across the world. This is 1990, looking at the Healthcare Access and Quality Index. Basically, if you're blue, you're doing fantastically. If you're red, you're doing really badly. 1990, not surprisingly, a lot of red in sub-Saharan Africa and parts of South Asia, and not much blue, a little bit of blue in Scandinavia, not much blue in North America. And then we fast forward to 2015, and the world looks a very different place. Lots of blue in North America, more blue across Western Europe and Australasia, still a lot of red in sub-Saharan Africa. And that's the challenge we have in terms of personal care today. You can then plot progress between 1990 and 2015 and look who are the outstanding performers. And you may be surprised about some of them. China has done particularly well, and those of you who know China well know that the government is investing enormously in trying to build its healthcare system for its citizens, as well as investing in R&D in the biomedical sciences. South Korea is doing very well. Turkey is an outstanding performer. Despite the politics of Turkey in other ways, they've invested in a health transformation program that is delivering high-quality personal health care to its citizens. Now, again, don't be frightened by this table, because, again, I want to show you over time how well you've been performing, sadly, at our expense. So, this is looking now at a time course, 1990, here, going out to 2015. So, we start off. The UK is down here, and you can see Israel between Ireland and Italy there. Israel starts off, and this is this index at 71.3, behind the United Kingdom at 74.3. Now we fast forward, and we go to 2015, and you can see that Israel has now increased up to 85.5, and the UK is languishing below 85 at 84.6. So within that short time period, one generation, your health system has flipped. It has advanced beyond the health system that I am in. That's a very interesting empirical question then to ask, why has that been the case? And I think the series Carl mentioned goes a little way to explaining some of that. We're talking about nephrology as well today, and one of the big gaps in terms of the quality of care is in renal care. This is Adir 11 and Ricardo Rota. This is taken from the World Congress of Nephrology, which was in Mexico City recently. Professor Oji was there with us. And one of the messages from this symposium that was held with the government of Mexico is that renal care is one of the most neglected dimensions in terms of personal health care today. There's a lack of political awareness, very little advocacy, too few services, often not enough doctors and specialized nurses to deliver care. Facilities are often very poor. There are often no national plans. There's no money. There are no registries to track the evolution of disease amongst the population, almost no research, and, as I say, very little political commitment. So we need to do a much better job in renal care. Okay, now let's go global. We're not going to compare Israel with the UK any longer, thank goodness. We're going to look at the world in a slightly different way. This is the progress in health in the world. And basically, we're doing a really good job. This is measuring, on the x-axis, years from 1990 to 2013, and then a measure of how well we're doing, which is called years of life lost. And if you go back to 1990, we were losing a lot of years of life lost. And then you can see that over time, that has gone steadily down. So the trajectory of progress in terms of our overall health is good. You can see that little blip around 1994 in the top line. No, it's not quite working. But the other injuries, do you know what that is? It's the Rwandan genocide. So you can see there that you can pick up in these kinds of estimates major cataclysms in humanity, but the overall progress is actually very, very positive. However, there is one area where we are not doing as well as we need to do, and this, again, brings in not just renal care, but a much broader set of issues around non-communicable diseases. This is Margaret Chan, who is the outgoing director of the World Health Organization, and this photograph's taken just a few weeks ago at the World Health Assembly. And Margaret Chan, in her closing address to the World Health Assembly, said this, that non-communicable diseases were the trend that most profoundly reshaped the mindset of public health. And she was talking about the duration of her tenure, which is the past 10 years. Now, in many ways, the world's response to the threat of non-communicable diseases has been exemplary. A political declaration was passed in 2011 dedicating the world's commitment to addressing these diseases. We achieved the Framework Convention on Tobacco Control, and that was led by WHO some years ago. We've had fantastic civil society mobilization against non-communicable diseases. Governments are considering tax measures to try and create incentives to shape behaviors from moving away from risk factors for these diseases. We've got a wonderful evidence base of research to tell us what we should be doing, and there's greater awareness and policy debate about how we address NCDs. However, this is a man called Ala Alwan. He's the former Minister of Health in Iraq, but more importantly, he led the World Health Organization's response to non-communicable diseases around a decade ago, culminating in the 2011 political declaration. And in an email he wrote to me during the World Health Assembly when we were reflecting on progress on NCDs, he wrote this to me, that progress has been inadequate and that there are major constraints impeding effective action by countries. So despite the successes, we have very good reasons for disappointment. There's no money. It's very easy to get money to spend on AIDS, TB, and malaria and women's and children's health. It's not so easy to get money to spend on non-communicable diseases because governments think that these are lifestyle diseases. They're our fault for the way we live our lives, and therefore why should they spend money on preventing diseases that are our primary responsibility? There are often no health systems. In other words, there's nothing we can do to actually intervene because there isn't a health system to deliver a medicine or to provide a health professional. The scale and the scope are too big. There's just too many diseases. It's not like one single retrovirus that you can target. Governments are too impatient for action. You can't give a vaccine and then prevent a disease. It takes years to see any benefits accruing from investment beyond the political cycle of 4 or 5 years that a government wants. What's called the 4x4 strategy, 4 key diseases and 4 key risk factors, isn't working anymore because we now understand that non-communicable diseases are more than just heart disease, cancer, respiratory disease, and diabetes, as important as those are. Mental health is never talked about, and yet it's absolutely critical for any consideration of human well-being. And anyway, you know what? The whole thing's just too damn complicated, so let's forget it and stick with what we know how to do. And I'm afraid to say that industry, Coca-Cola and the like, are now becoming the new big tobacco, and they're thwarting all of our efforts. We've actually got a window of opportunity because in 2018, in September, there's a big world review of progress on non-communicable diseases. And so over the next 12 to 18 months, there's going to be increasing political attention to how the world is doing. That's an opportunity for us to try and accelerate action and to address some of these reasons for disappointment. But there are reasons, and we have to figure out what we do about them. Now, it would seem on first look, that this vision of personal health, which is all down to access and quality healthcare in our health systems, and global health, which is looking at all these big political issues around health, they seem very different worlds, not connected very well at all. So can we create a single vision for health in our world today? Well, as Margaret Chan was leaving WHO, we had a new Director General of WHO, Dr. Tedros. He likes to go by his just one name, Dr. Tedros, in the Ethiopian tradition. He takes over as leader in July of this year. And in his opening press conference, he said this: all roads should lead to universal health coverage. That is his major goal, and in many ways the world's major goal in terms of health for the next 10 years or so. Now, what is universal health coverage? Well, the classic way of explaining it is, of course, with this cube. And it's a very simple idea. It's almost Euclidean in its simplicity. And that is that for universal health coverage, you're measuring the proportion of the population that you're covering, whether it's from 0 to 100%. Your goal, of course, is 100%. You're measuring the number of interventions, 0% to 100%. So clearly, for many countries, you can have access to simple interventions. But if you take issues like dialysis, far too many countries do not have access to dialysis facilities. So what proportion of interventions can you cover? And then the third element is, how much can you pay? Because clearly, a patient's going to find it very hard to pay for expensive, high-quality services, and that's where insurance or a single-payer system, as we have in the UK, then becomes important. So how much can a country afford? And what you're trying to do is navigate your way across the cube from 0% of everything up to 100% of everything. Now, some people have seen universal health coverage in very grand terms. And they've characterized the evolution of human society in 3 levels. First, we went through a demographic transition. We shrank child mortality and expanded those who lived to an older age. Then we went through this epidemiological transition, away from infectious diseases and now more towards non-communicable diseases. And now we're going through the third great 21st century transition, and that is delivering universal health coverage to 7 billion people on our planet. That is the inspirational, aspirational goal for our times. And the lesson, of course, is that there's no single answer, single blueprint. There is no engineering drawing that can apply to all countries of the world. Every country will develop its own path, reflecting its own culture and its own legacy from existing health systems. But mark my words, the prize is great. This is a graph taken from a commission we published from Larry Summers and Dean Jameson a few years ago, and the prize is ending preventable mortality. If you start with countries, low-income countries, the blue line, with high levels of child mortality, it's quite possible that within a generation we could end preventable mortality among women and children based on the knowledge we have today if we could deliver universal health coverage. But there's a but. There's always a but. And what's the but? Well, you recognize SARS and Ebola. The but is that we can never plan adequately enough for unexpected events. And when unexpected events comes, this wonderful application of science, reason, and evidence then becomes extremely problematic. Jeff showed a time cover. Here's another time cover from just 2 weeks ago. And their conclusion, it's not the Lancet and it's not the New England Journal of Medicine, but I'm not sure that Jeff and I would disagree with this conclusion. We're not ready for the next pandemic. And quite clearly, if we take all countries of the world into account, we're absolutely not ready. Why is that? Let's go back to my healthcare access and quality index. I showed you the top 30 countries. Here are the bottom countries. And I want you to notice something here. Which countries do we have in this list? We have Guinea, we have Sierra Leone, and we have, 2 from the top, you can see there, Liberia. Which are those countries? That's where Ebola was. So what's the lesson? If we want to deliver secure global health, which means
secure global health security, the only way that we can do that is by delivering excellent individual health security, which means universal health coverage. So the vision for improving personal health care is directly linked to our vision for securing sustainable and reliable improvements in global health. The two are utterly related. Global health is completely dependent upon achieving better personal health. But that threat, that worry, is what has led people like Martin Rees, the former president of the Royal Society in the UK, to write and continue to argue this. We want to talk about the flip of a coin. Here's another flip of the coin. I think the odds are no better than 50-50 that our present civilization will survive till the end of the century. Because if we're not prepared, and we are not, for a new pandemic, and this time the pandemic really does kill, like it did in 1918, but maybe even worse, then we are in serious trouble. So perhaps we need to look at our problems a little differently. Just on Sunday, when I took a flight from London to come to Israel, at 9:58 on Saturday evening, just a few hours before, we had the third terrorist attack in the United Kingdom in just as many months. We've not seen anything like this in my country before, until going back to the Troubles, as they're euphemistically called, the conflict between the Irish Republican Army and the United Kingdom government. And truly, we don't really know how to handle this. And just in the last week of an election, if you're following the British media, you will see that there are now recriminations between political parties struggling to find advantage for themselves in the last few days before we vote on Thursday. But at the same time, truly uncertain about what the best steps are that we should take to address these horrors. Perhaps we should be looking at the future of health then in a bigger way. The way Tony McMichael, who passed away in 2014, but thankfully had completed his manuscript of a book that was published just a few months ago, looking at climate change and the health of nations, perhaps we should be thinking not just in terms of personal health or even global health, but actually we should be looking at the fate of our civilizations. How healthy are our civilizations? It's not much good delivering fantastic personal care or delivering protection from pandemics if we still are creating a world which can be destabilized, indeed destroyed, through violence and terrorism. And chronic threats too. Here's one: pollution. And if you look at the global levels of pollution, that's the green line going across the middle of that graph, you can see that it's gradually going up, and for some countries like Bangladesh and India, it's going up quite dramatically. This is a good curve for the United States. It's good to be at the bottom of the table here. It's not just affecting the human species, and this is a very important lesson I think we need to think about in our era of sustainable development. We cannot exist as a species alone. Our success as a species depends upon the success of other species. And if you look at, and this is an example of extinctions of vertebrates, that over recent times we're seeing an almost exponential increase in the extinctions of vertebrates. Our biodiversity, on which we depend, is being destroyed because of the way we are hurting the fragile planet on which we live. It was partly because of these considerations that a few years ago we raised the possibility that we needed, instead of talking about public health, we needed to talk, or even global health, we needed to think in terms of an idea we called planetary health. An urgent transformation, we argued, is required in our values and practices based on the recognition of our interdependence and the interconnectedness of the risks we face. We were very grateful to the Rockefeller Foundation in New York for providing a grant so that we could launch a commission to investigate this idea of, in a sense, the fate of civilizations. And indeed, we converted that idea into a definition of planetary health. Put simply, planetary health is the health of human civilizations and the state of the natural systems on which they depend. Oh, thank you very much indeed. Now I've got three. Right, hang on. I tell you what, I'm going to put that in there. Thank you, Fuad. You're great. You're great. We identified 3 challenges. The first challenge was one of imagination. Can we rethink what it means to be a prosperous society, a prosperous world? It can't only be about creating more wealth. There's got to be something more than money in our world and more than money in the way we measure our world. Can we rethink what we mean by knowledge? Because we're creating supreme amounts of knowledge, but we don't seem to be applying it in the ways we need to apply it to affect the kind of change to protect our civilizations. And thirdly, we're really good at talking. We're really good at publishing papers. We're not quite so good at doing anything about it. So can we act faster? Can we act more effectively? Because we are living in a different age. I took my daughter to see all the Ice Age movies. And the Ice Age movies, you may remember, were all set in the Pleistocene era. Well, the Pleistocene era was 1.8 million years ago. And we've been living for the last 11,000 years in the Holocene era. But from about 1950, we've been living in a very different era of human history, and we have to get to grips with it, get used to it, the Anthropocene. And that Anthropocene era means that the way we live, the way we think, the way we work together has to change. At the Lancet, we've tried to address these issues by looking at, for example, the issue of climate change and presenting it as what we call the biggest threat to global health in the 21st century, reviewing progress on that by presenting it actually as the biggest opportunity, because if we could get to grips with the climate crisis, then we could look forward to a longer period of human health and then trying to define this idea of planetary health. We've now set up with Christiana Figueras, who guided the Paris Climate Agreement to its success until recently, with Nick Watt, with funding from the Wellcome Trust, a standing commission that we've called the Lancet Countdown, which is now using the latest scientific evidence and tracking that evidence across a range of domains to see what progress we're making. We're trying to use the Lancet not just as a medical journal, but also as a mechanism for holding governments accountable to their promises and commitments from Paris. We've launched an open access journal called Lancet Planetary Health to try and create a new discipline to look at the fate and health of civilizations. Now, we do have challenges. There are people who don't quite believe what we will believe, what the science says, and we have to think about smart ways to address those challenges. And it's not going to be easy, as we know just from the last week's decision from the United States. But I'm optimistic, so I pose a challenge to you. Who is going to be the first professor of planetary health in Israel? And could they be here at Rambam? Because there's a lot to learn from Israel, as we'll talk about tonight, I hope. There's a lot to learn from Israel in terms about building a civilization, protecting a civilization, and strengthening a civilization. Very quickly, new possibilities, because this is all very conventional. You know this man, Professor Skoreski, my friend and teacher. I've learned a lot from Carl, from many of you, of course, in the room, but I've learned particularly from Carl in the last 2.5 years. And as Carl mentioned, we did write together this final paper in the Health in Israel series, looking at health and beyond. And one section of that paper looked at harnessing the strength of religious belief to promote health and well-being. In the Western world, almost finished. In the Western world, we don't do very well at linking the sacred and the scientific. And we proposed that we needed to do a better job. And in some parts of the different faiths, there are efforts to try and make linkages between the health of civilizations and faith. This is Pope Francis in his truly inspiring, I do encourage you to read it if you haven't, encyclical on climate change and inequality, where he talks about the earth herself burdened and laid waste among our most abandoned and maltreated of our poor. We wanted to work with the Vatican and the Catholic Church to look at the future of humanity, to see if we could build a linkage between science and faith. 1.2 billion people in the Catholic Church, so that would be a big win if we got it right. And we held a conference in April this year to try and start that dialogue. And I say this not because I want to talk about the Lancet or me, I want to talk about nephrology, because it's a nephrologist that's leading this initiative, Beppe Ramuzzi, a former president of the ISN. At this meeting, one climate scientist from Ireland pointed out that we only have one generation, 20 years, in order to get this right. We have a very limited time window if we're to get our planet and our people back on track. So when we went to see the Pope, Beppe Ramuzzi, that's the man in the middle, shaking hands with Pope Francis, was leading this conversation. So all power to nephrology, I say. You really are leading in terms of this global conversation about the future of humanity. And very lastly, it was Rambam where I began my journey in the past 2.5 years. And I'm so grateful to Carl and to Rafi for their generous invitation to come here, about which more later. And of course, this is Schrager Blazer with a journal that's much better than either the New England Journal or the Lancet, your own journal, which I'm very proud to have published in, and maybe Jeff's published in there too. And there we are in front of Maimonides himself. It's been quite a journey. It's been quite an experience, not just a scientific experience, but also an emotional experience. And here we are, an Orly Manor there, launching in Tel Aviv just a few weeks ago with Rafi chairing. And you've seen this picture already. When I stood here 2.5 years ago, and you'd asked me if we would have had a picture like that and a meeting like this, I don't think I could have quite appreciated that we could have made that journey together. So I only have 2 words to say as I conclude. A deep, sincere, heartfelt thank you.